நல்கிடும் வைந்தமிழ் அன்னாய் தோன்றுடல் நீ உயிர் நான் மறப்பேனோ செந்தமிழே உயிரே நருந்தேனே செயலினை மூச்சினை உனக்களித்தேனே நைந்தாயனில் நைந்து போகுமென் வாழ்வு நன்னிலை உனக்கெனில் எனக்கும் தானே முந்திய நாளினில் அறிவுமில்லாது மொய்த்தனன் மனிதரா புதுப்புனல் மீது செந்தாமரை காடு பூத்தது போல செழித்த என் தமிழே ஒளியே வாழி செழித்த என் தமிழே ஒளியே வாழி செழித்த என் தமிழே ஒளியே வாழி.
I'd like to invite Mr. Manimaran, Chief Operating Officer of Vinayaka Missions Super Specialty Hospital, to deliver the welcome address.
Good evening, ladies and gentlemen. I would like to start with apologies for the delay, unexpected technical glitches, so it happens, and we value all of your times. Apologies. So I'd like to first of all start with welcoming the hero of this special occasion, Dr. Anand Chockalingam, the chief guest. He's a renowned cardiologist from Charleston Area Medical Center, West Virginia, USA. So he's basically from India. Introductions will follow. Thank you, sir, for having taken all the pain to travel all the way to India and spend time with us. The little time that he has in India, he has been grateful enough to spend some time with us. Thank you, sir. I would like to welcome Mr. Suresh Samuel, the Chief Strategy Officer of Vinayaka Missions Group. Thank you, sir, for coming. And I would like to welcome Dr. G.R. Ravi, diabetologist from Chennai Diabetic Center. So it was a great pleasure having you here this evening. Again, sir has taken all the pains to travel all the way from Chennai to just attend this function. And my welcome goes to the entire AVMCH team, Dr. Rakesh Segal, Dean Research, Dr. Mani, Dean Academics, Dr. Dandapani, Medical Superintendent, and Mr. Suresh Samuel, Director HR, Dr. Vidyavati, HOD of Medicine. And I would like to extend a very warm welcome to the entire team of VMSH doctors, starting from Dr. Hari Menon, our medical director, and the team of VMSH doctors to have graced the occasion. And a very warm welcome to Dr. Siva Subramaniam, interventional cardiologist from Vinayaka Missions Hospital in Salem, Salem. Again, he has traveled from Salem just for this function. So, last but not the least, a very, very warm welcome to the entire medical fraternity of Puducherry. I know it's a very busy working evening, a Thursday evening. A lot of you would have spared your OPs and come to attend this function. But please be rest assured, sir and madam, this evening that you spend here with us is definitely worth the time that you're spending here, for the academic knowledge that you will get to have shared here. Thank you very much, and let's move on to the program. Thank you.
Thank you, Mr. Manimaran. I would like to invite Dr. Selvam, consultant, Vinayaka Missions Super Specialty Hospital, to provide introduction of Cardiac Metabolic Center.
Respected dignitaries, esteemed colleagues, and dear friends, good evening. It gives me great pleasure to share a few insights on a topic that is rapidly gaining momentum across the healthcare landscape. That is cardiometabolic care programs and the emerging opportunities they offer. Need for cardiometabolic care. What is cardiometabolic program? components of an ideal program, emerging opportunities, who can lead these, closing thoughts. So these are the 6 topics I am going to give in a nutshell, short period. Why cardiometabolic? Why not other vital organs? It is because the heart metabolism axis is the most dangerous, urgent and actionable. That said, future care models will likely expand to hepatocardio-renal metabolic clinics as personalized, organ-specific care becomes more integrated. This is the bitter truth. Bitter pill: 20% of the doctors are obese, 53% diabetic, and 24% hypertensive. In the society nowadays, the patients are living longer than the doctors. Doctors are the one of the among worst patients nowadays. This is the scenario. The one article from this edition, this is the Indian senior citizen, they are dying rich but not living rich. This is the truth. We mature more with the damage, not with the age. Why? This is the mindset of the people nowadays. The need for cardiometabolic care, we face a rising tide of interconnected non-communicable diseases like diabetes, onwards everything. So the multidisciplinary care is not optional, it is essential. So the dangerous domino effect. If somebody is obesity, that is leads to insulin resistance and diabetes, as we all know. Diabetes and hypertension, organ damage is must. Dyslipidemia and hyperglycemia, heart disease is must. Fatty liver, for everything, inflammation and worsen metabolism. One disorder is a warning, 2 or more is a time bomb. This is our South Asian phenotype, that is TOFI, thin outside, fat inside, skinny fat syndrome. So in spite of lower BMI, we Indians have more abdominal fat, more insulin resistance, higher levels of C-reactive protein, lower levels of adiponectin than all these things. This is the thing. Visceral fat in the obese person as well as in the lean person, you can be thin but still carry a dangerous visceral fat. So why dangerous visceral fat? Because of our diet pattern. So this is a simple breakfast. This is not a simple breakfast, but we eat more of carbohydrate, that is refined carbohydrates, than protein. That's the main problem. Mistakes done by mouth, punishment given to the feet. India, diabetic capital of the world. Goa, 26.4% prevalence. The next alarming thing is Puducherry, 26.3%. So alarming rise in youth metabolic syndrome. Traditional methods are no longer sufficient. So this is the map where you can see the diabetes prevalence in the southern part of the India. So this is the recent national survey. In recent national survey, Puducherry stood first for statewide presence cardiometabolic disorders. This is really alarming. So this is the timeline of type 2 diabetes happening in Indians, South Asians. So compared to white Europeans, we are developing cardiometabolic disorders, diabetes, obesity, everything, earliest stage. So why is a cardiometabolic care program as an integrated multidisciplinary approach that screens early, offers lifestyle interventions, coordinates care across specialists, monitors with the digital tools, focus mainly on prevention, prediction and proactive care. We will be healthier if docs speaks to each other more often. This article also came in the newspaper. So components of an ideal program, these are the main components: history, anthropometry, blood biomarkers, as you all know, ECG, ultrasound, echogram, all these things are components of ideal program. So our visionary chairman, Dr. A.S. Ganesan, he insisted as is the true key person for the initiative and unwavering support establishing a world-class cardiometabolic center at Vinaya Mission Super Specialty Hospital. So in Vinaya Mission, we have precision blood biomarker testing, personalized epigenetic hair root analysis, and body composition analysis, and MRI to look for amount of visceral adiposity, AA-assisted CT coronary angiography, ultrasound, fibroscan, sleep study, pulmonary function test, and many more. So we have world-class interiors with excellent ambience. Like these are the few pictures in our institution. We are also proud to have a full panel of super specialists under one roof: internal medicine, functional medicine, diabetology, cardiology, neurology, gastroenterology, nephrology, pulmonology, and gynecology, nutrition, physiotherapy, and yoga therapy as well, to deliver an integrated patient-centric approach. They are the consultants. So finally, the digital integration. These are the emerging opportunities. These emerging opportunities Dr. Anand Chockalingam will tell better way. So who can lead us? This change, primary care doctors, specialists, lifestyle experts, institutions can launch pilot programs, medical colleges train future leaders, and hospitals can establish dedicated clinics. The 5 pillars we are focusing in PACE. That 5 pillars: first, prevention, prediction, precision diagnosis, personalized treatment, primordial care, and reversal. These are the 5 pillars. With the expert guidance of Dr. Anand Chockalingam and Dr. Saravanan and their expert team, we aim to address all the 5 things. Then closing thoughts: cardiometabolic care is a necessity. Better outcomes, lower costs. Encourages research, collaboration, and innovation. Reimagine fashion care, not in parts, but as a whole. This is one Tirumular Vaku. Udambar Adiyil, Uyirar Adivar, Tidambada Menyanam Seravu Matar, Udambai Valarkum Ubayam Arinde, Udambai Valarthen, Uyir Valarthene. This is cardiometabolic care. Someone talk to you in their free time, and someone free their time to talk to you, like our Anand Chockalingam. The next talk is by Dr. Anand Chockalingam. Thanks for your patient listening. Thank you.
Thank you, Dr. Selvam. Dr. Anand Chockalingam is Professor of Cardiology and Director of Cardiometabolic Program at CAMC Institute since December 2023. His research at the University of Missouri, with over 70 original publications, focused on premature heart failure due to mental and metabolic stress. He collaborates with mindfulness experts, behavioral psychologists, integrative medicine practitioners, exercise and nutrition scientists to improve heart failure outcomes. He has pioneered Heartful Living, Advanced Cardiac Energetics, ACE, a novel self-inquiry in mindfulness empowerment program for virtual cardiometabolic care. He works with the American College of Cardiology and several medical associations for building physician resilience. ACE reverses biological heart age and premature heart failure by addressing NASH and NAFLD, diabetics, hypertension, and inflammation. He is director of Diastolic Heart Failure Clinic and Cardiac Rehabilitation, where his team is exploring scalable integrative programs for heart failure and CKM metabolic syndrome care globally. Welcome, Dr. Anand.
Good evening, friends. Can you hear me back there? Is the mic audible? Good evening. Thanks so much for inviting me to Puducherry. This is such a pleasure for me to come back to our country, to our place, and show that we can make a difference. My interest in cardiometabolic space started at the beginning of my career as a cardiologist. It took me about 20 years to get good at doing magic and teaching magic to my postgraduates. And the fun and the excitement that I bring to India is that we can show our patients and their families how to do this level of incredible self changes. That's what we are calling magic. Before Manjaro and Ozempic, the latest weight loss injections, the work I was doing was considered sort of something in the sidelines. But it became mainstream, got highlighted only in the last 3 years, thanks to these newest injections that allow people to lose 15, 20, 25% weight. So once cardiologists got to realize how much healthier their patients were becoming, then this weight loss became central to the care of our patients. So in Charleston, West Virginia, I work nearly 1.5 years now, and I lead the cardiometabolic program, the world's only diastolic heart failure reversal clinic, because everybody is talking about managing chronic disease. For 15 years, our focus has been reversing cardiometabolic problems, and I also lead the cardiac rehab program. So what have we accomplished that is simple, intuitive, and empowering our patients? That's what we're going to see in the next few slides. So this is a slide from Eli Lilly, the makers of Mounjaro. This slide is 3 years old. The reason I'm showing this is obesity is prevalent and increasing across the world. And this is what Eli Lilly started focusing on in the last few years, recognizing that half the heart failure is due to stiff hearts. When the heart is stiff, we cannot do balloon or bypass surgery or even heart transplant. The reason is there is no blood supply issues, the squeeze is still normal. Then why has the heart failed? The heart has failed because of too much metabolic load, especially long-standing hypertension, diabetes, and that is what causes diastolic heart failure in the 70s. But my focus is on those who have it prematurely, in the 30s, 40s, and 50s. Why would heart fail so early? Because of mental stress and extra weight in the body. So that has been my work for 20 years. So to diagnose, there are so many tests that are available, so that is what we are starting to implement globally. And the risk factors for heart failure are too many. This is not something that is new to us. See, if you look at this busy slide, you see many lifestyle factors like sleep apnea, diabetes, hypertension, anemia, coronary artery disease. Some of these we can fix. Only now we are realizing that the pathophysiology is extremely complex. So many things are going wrong before the heart fails. The reason for that is the same myocardium that we carry was already optimized close to 100 million years ago. So that is a realization that we have to become humble about and recognize that if the heart is failing despite being optimized over so many generations, then there could be some other lifestyle issues beyond a simple pill, simple molecule that we can address. And this we all recognize. Heart failure means, we all know it is trouble breathing, it is fluid buildup, and it is also orthopnea. Our Prime Minister recognizes obesity as the latest threat to our national security. So this did not exist 25 years ago. How come this disease becomes a national problem? Because obesity is not a disease that doctors can fix. The obesity that the world is dealing with is a change in society. It's a lifestyle and social cultural change that is now coming to the doctor's attention. So we can do what we can, but change has to happen at many more levels than just some injections or surgeries. So diastolic heart failure is because of 5 or 6 things, same things: kidney failure, liver failure, hypertension, diabetes. But right in the middle, appropriately, is obesity. Why is Eli Lilly saying obesity is important? Because for the last 10 years, they have developed the world's most powerful medicine, tirzepatide or Mounjaro, that does wonders in causing weight reduction. Fatty liver, metabolic dysfunction associated steatohepatitis did not even exist when I studied medicine 35 years ago. Now this has become the #1 reason for liver dysfunction, and it manifests as fatigue. If you ask how many people are fatigued in this room, I think many hands will go up. Not because of this one reason, because there is so much overlap with life itself. And then abdominal pain, hepatomegaly, and what we see is unexplained further weight gain. Why do Indians have more liver dysfunction than every other community. It might be in our genes, it might be that we don't screen for this early enough, and there is high, Dr. Selvam just pointed out, our diet is putting us at even more risk from earlier in life. We eat primarily carbohydrate rich food. PCOS and hypothyroidism, all these may be the reasons why we see this more in our community. And then what I'm showing here is the scariest thing that I learned only few weeks ago. So I'm using ChatGPT to generate this slide, but what I'm showing you here is by 35 years, our Indian community can develop liver failure, not NASH, MASH, fatty liver. Liver failure, that means death unless we transplant the liver. So this is what I'm discussing with several liver transplant programs in Chennai, because they are more interested in this cardiometabolic space than cardiologists. Cardiologists are going to catch on in the next 3 years, 5 years, but liver failure means death once the liver is failed within 2 years. And that, if it can happen in 60-year-olds in the US, it's happening in 40 and 50-year-olds in India. But at 30, the liver can fail, and this is the pathway for that. And this is data from India, China and US showing across the world fatty liver, extra weight in the body, is causing the #1 reason for liver transplant already across the world. Hepatitis and alcohol related liver failure are less than 50% already. And in the next 20 years, this is going to become even more of a problem. This is a beautiful study done 10 years ago. I don't expect anybody to read the slide. But the reason I'm showing this is, before they transplanted the liver, before they did, this is a study on gastric weight loss surgery that causes significant weight loss. Before weight loss surgery, they did liver biopsy. And after successful weight loss, they repeated liver biopsy. And what they found is dramatic improvement in fatty liver metrics by biopsy. And for that level of liver recovery, we are seeing 85% disappearance of fatty liver. For that, what is required is right up there. How much weight reduction? 25% weight reduction. Do we know of anything that does that? For 45 years, we had gastric weight loss surgery that does that in 1/3 of patients. We accomplish 25% weight reduction. So that is what it takes to address fatty liver. Why I show this is, that is what it takes to address premature obesity related diastolic heart failure also. So all these are obesity related inflammatory problems. This slide shows the liver transplants, and I'm showing in 2025 versus 2055, 20 years from today, liver transplant is not going to grow significantly. That's what I'm showing. We are already doing 5,000 liver transplants. We are probably going to do 10,000. But the need for liver failure related transplant is going to skyrocket in US. That is the blue curve. And the yellow curve is where it's going to take off even more in India, unfortunately. And only 5% are going to get liver transplant. 95% life is going to be lost, not in the 70s and 80s, but in the 30 to 50 age range. That is why our Prime Minister is trying to bring our attention, not only for doctors, but also for the common people, towards prevention. So this is the prediction for our country in the next 20 years for fatty liver alone. And this is the lean NASH, lean metabolic syndrome, that leads to liver failure 10 years earlier in India. Liver transplant in India happens in the 40s compared to the 50s in the US. So this is the math that we came up with for fatty liver also, but for heart failure, we are very confident that based on BMI, we are able to predict weight-related risk for heart failure. The simple math that we are not giving this only to the doctors. We want the common man who has Google or internet to find their BMI, and based on their BMI, go to their doctor and say, doctor, is my trouble breathing? Is my swelling in my feet? Is my requirement for diuretics, Lasix for the last 3 years? Is it due to my heart failing? Because my BMI is 40 and my age is 60, age plus BMI reaches 100. Is my heart failing because of my weight? We want the people to ask their doctors. Then the doctor will refer to a cardiologist, specifically asking, is there diastolic dysfunction? But if it is premature diastolic heart failure of obesity, echo, including Doppler echo, tends to be normal. So it's a very challenging diagnosis even today, even for people who focus on this. So we have developed protocols that are specialized and help us use blood tests, echo parameters, stress echo, and other tools, including cardiac cath, sometimes is required to make this diagnosis of premature heart failure. And this diastolic heart failure, when the ejection fraction is fine, can anybody guess how frequent it is in the US today? It's not 1 or 2% of all heart failure. This is 60% of all heart failure in the US. In India, it's already 30 to 40% of all heart failure. So I'm not talking about a rare cardiogenetic disease. I'm talking about real world heart failure, which is the #1 cause of death. Of that, 60% is due to diastolic heart failure, where we cannot put any more stents or do heart transplant. This is what we call the magic that patients learned and they are teaching us. So now that's what I want to inspire all the physicians, cardiologists, endocrinologists, diabetologists, and gastroenterologists to recognize we are dealing with the same disease spectrum. This woman was hospitalized 15 times within 12 months. The red arrows show the number of times she was hospitalized. She learned advanced cardiac energetics in 2001. It's been 4 years on guideline therapies by the first admission, by the 12th, by the 15th admission. She has not come back even once since she learned our program. It is that powerful in keeping people out of the hospital. The yellow color is the visceral MRI looking at adipose tissue. In the subcutaneous is the yellow color. Pink color is the visceral fat. Visceral fat is 10 times more atherogenic and metabolically active. There is only one other location which is even more active than visceral fat. Anybody knows? Hepatic fat, fat in the liver. That is 100 times more atherogenic and metabolically active than even visceral fat. So we need to address extra weight everywhere, but especially for those who have visceral fat. And who has more visceral fat than US? We have more gold than any other country in the world. That's what I've learned. Just like our women accumulate gold, our men and women accumulate visceral fat and hepatic fat. And that might be cultural, it might be genetic, it might be diet. Whatever the reason, we need to address it if we value our longevity, our health. Okay? And what I'm showing you here is that pink color within months through lifestyle regressing dramatically. Okay? By the last lower picture, you see the pink color has come down. So we need to do serial MRI to track the visceral fat. This is where the next 3 or 4 patients are the reason why I left my job after 18 years in Missouri. I was initially a research academic person looking at early heart failure. In 2005, 2010, I looked at so many diet ways. 2010 to 15, I tried so many ways of changing exercise, implementing interventions with high intensity exercise, weight training, home-based rehab. But from 2015, we started empowering people with the right knowledge. So this is my head nurse. She's 64. She is referred to me by the heart failure expert at the university hospital saying she's 64 with heart failure. So what is her BMI plus age? 99. So very close to 100. So BMI is 34. Do you see many people with BMI of 34? That's not a big BMI. And she told me, Doc, don't worry about my weight. It's only 88 kilograms. But she's a small person. She's not very tall. So 88 kilos allowed BMI of 34. But then she's asking, Doc, weight is not a problem. Then why am I saying weight is a problem? Because in her 30s, 40s, and 50s, she was young enough to withstand that weight. At 64, the heart became too stiff. She has developed severe pulmonary hypertension with exercise. So at rest, the PA pressures are okay. When she gets on the treadmill, pressures in the lung goes sky high. Bottom line, she can't walk from one room to the other. She's 6 months to retire. She's spent 40 years working for our university, and she has only 2 years to live. when she starts this program. And what happens to her weight? Electronic medical records. So these are not graphs that I'm drawing. EMR is suggesting that she has made magic happen. How much weight has she lost? Half of her entire weight is gone within 10 months. And now it is 4 years since this, 3 or 4 years since this happened. She's feeling like a 20 or a 30-year-old. She's off all hypertension medicines. She's not requiring any diuretics. She's bicycling 30 kilometers, 40 kilometers every day with her teenage grandchildren. So this is the transformation that is possible in heart failure patients below the age of 70. Above 80 also we have some success, but it takes more effort from my team to work one-on-one above the age of 70, 80, 85. Even in the 90s we have some patients. So this is CKM syndrome. Has anybody seen this slide? How many of you have heard of this word called metabolic syndrome? Everybody has heard of metabolic syndrome because Dr. Cravens in Stanford started research in that in the 1960s. So we all understand that obesity, diabetes, hypertension, hyperlipidemia, they're all part of this cluster that then leads to heart attack, atrial fibrillation, stroke, and kidney failure and death. That much we are familiar with. The only addition, the first stage 1 is obesity, is separated from metabolic syndrome and placed as its first starting point of all the other problems. This happened only 1.5 years ago. And who is promoting this? The American Heart Association is highlighting this not only as metabolic but as cardiac kidney metabolic syndrome. So this does not exist until 2023. And this is not any new science. It is just the opinion of some experts. And they are saying we need to address CKM as a continuum across the life. I'll finish in the next few minutes. What we are saying is we've spent 20 years in this space. We are saying it's not a one-way road, it's not a syndrome, it's a dynamic that can be reversed. And to reverse it, we need an integrative approach that uses technology and the right empowerment of the patient and his family to make the needed changes. And this is what we got successful at about 7-8 years ago. And this is the reason I moved to Charleston, West Virginia about 1.5 years ago, because the leadership there is supportive of building this out as an integrated healthcare program. So this is what we have now for heart failure. That is what is my job. But in the middle you see heart age. That is where we have people with pre-heart failure. That means liver failure, sleep apnea, hypertension, diabetes, all these metabolic problems we are able to address before it leads to heart failure. And then this heart to heart is even more ambitious because it deals with young minds, people between the age of 12 and 30. We want to inspire young minds, students towards health at a young age so that society will be healthier moving forward. And that is done by students, not by doctors or teachers. So we want to improve longevity. We want to make everyone live 100 years. But even more important than living 100 years is being healthy today, right? So that is what our emphasis is. This is how we reverse biological age. I'm not going to go into detail. Some of it is medical, some of it is genes, some of it is interventions, but we make people younger. How much younger? And this is a study that shows that if somebody has extra weight for 15 years, severe obesity, that is sufficient reason to make the heart stiff enough to cause diastolic heart failure. 15 years is enough. But the 15-year clock, unfortunately, now is starting 5, 10, 15-year-old children. So by the time they are 30 or 40, their heart has enough reason to fail. Make sense? So this is our very simple heart age calculator that we have implemented about 6 years ago because we learned that we can make this work. And this is based on not invasive testing or genetic testing. It is based on metabolic risk factors. What is your blood pressure? What is your height? What is your weight? Are you diabetic? Do you smoke? That's all we ask. And we are able to predict an individual's biological, metabolic, heart's age. This metabolic age predicts how many more years we have left in this world. Our chronological age only tells us our past, but this tells us how much future life we have left. And this is the pathway that empowers the mind and we measure it through metabolic reversal of natural ketosis. So I'm not going to go into the details, but this is what we validated about 6 years ago for cardiorenal patients in the hospital who are dealing with advanced heart failure and not able to get out of the hospital. If they are in the hospital and getting guideline therapies, procedures, bypass surgery, they should be able to go home to their life. If they are not and they are stuck in the hospital, our program still works. This is the patient that made me give up my 18-year job and move away from what was my familiar research and academic job, because this is what he is, about 270 kilograms. He's gone to all the doctors in the world and he's on guideline therapies and he's not getting better. He's got only 2 more years to live, at best 2 to 3 years, and he starts our program. This is what happens to him. Within 10 months, he loses 62% of his entire weight. 10 months. And then I said, I don't need to do research. Let me just build programs that will help more people in my lifetime. I don't have infinite life. So that is why I moved to Charleston. And I thank Suresh Samuel for trusting me enough to bring me and try to build a program here in Pondy that can potentially change lives across the world. Because this type of result, I want to show just this one picture to every patient in Pondy and say, do you want to get healthier? Not all our patients are obese. Some of them are thin. Still, this is the one picture that communicates what I have accomplished in 20 years. And this is the actual heart age reversal program. This girl is 34. She comes to me because she's come to cardiology clinic for 10 years. She's had hypertension and chest pain, anxiety, depression, and PTSD from being homeless, post-traumatic stress. After 10 years of living life like this, at 34, her heart is 63 years old. And within few months, her heart biologically becomes 30 years of age. And now she is the head of the program that does this in Missouri. This is the platform that we have built about 4 years ago, and we do this program across the world, English-speaking world, Australia, UK, Canada, India. We have patients. And this is a 34-year-old in Namakkal who lost nearly 50 kilograms within first 4 months of our program. So this is what we are able to already deliver across the world using technology. This is my center for cardiometabolic health, where we work with several subspecialists and we work with technology. In US, people can see me virtually. I don't need to auscultate. I don't need to sit down and do any procedures, because if they are in California or New York or Florida, it does not matter. Oftentimes, by the time they come to me, they've already been evaluated appropriately by all the subspecialists, and they come to me with all their results, so I can get them directly into the advanced cardiac energetics program. That is what we are doing currently for the last about 4 years. So this is the result of our program. This is what is embarrassingly, stunningly good results. 90 heart failure patients, we are seeing weight loss of close to 20%. This is better than Mounjaro Ozempic, because they take 12 months, we take 4.5 months to create 18 to 20% weight loss. This is our outcomes. And lipids, cholesterol comes down 25%. Hemoglobin A1C is down by, from 10, hemoglobin A1C comes down to 5 across 90 patients. Average age is 50. Many of them have kidney issues, lung issues, and so many other metabolic problems. What is happening to their blood pressure pre and post ACE program? Blood pressure drops, systolic and diastolic, 35%. There's nothing in the world I've seen that does this. So if 90 patients can do this using the right technology, why don't we scale it to reach a larger population across the world? So for that, we need to first convince our providers. That's why I'm here, to answer any questions you may have in the next few minutes. I'll stop with this last thought. This is tirzepatide, Mounjaro. This result came out only 2 months ago in New England Journal, saying Mounjaro sustains weight loss for 3 years. If you give the injection for 3 years, the weight loss sustains for 3 years. But the trouble is, 20% weight loss, half of it, the 10% or more, may be core muscle strength. So people may be getting weaker during the weight loss. This is a real concern. Second concern is what these three girls have. They've already been on Manjaro, they're still on Manjaro, and they want the ACE program because there is a plateau effect. They want even better results. Manjaro, there's a below which it doesn't go. So they want further weight loss. And the third real concern for cardiology especially is if people stop it at 7 months, which is the average real world compliance, weight regain can be even more dangerous compared to when they started out the program. So this is the real world we are dealing with. And what I'm showing you here is a complex path for how to land a plane after the engine fails mid-air. There is a protocol. A plane in mid-air after the engine stops can still be safely landed. That is the level of individualized care that many of these patients received to achieve this level of success that you saw in the pictures. But now that we've done it, we have 4 or 5 generations of patients that have succeeded. Now if we deliver it as technology-based healthcare, we are confident these outcomes can be reproduced. This is Denise Chiartas. When I relocated to West Virginia, she said, "Doctor, don't worry about smiling, relaxation, meditation, because I teach DNORNISH related advanced cardiac rehab. I teach diet, I teach yoga, I teach relaxation." And I asked her, "What's your heart's age?" So within 6 months, she herself turned 10 years younger. So the experts also need this care because she's taught relaxation and diet for 30 years. This is her specialty, but we can make her younger too by 10 years within 6 months. So she has now become the head of my virtual care program in West Virginia, cardiac rehab. So we are inspiring not only the community, their children and grandchildren, but even more important is to get buy-in from doctors and medical community so that our society will become healthier and move in the right direction. So this is our advanced cardiac energetics program in Charleston, but we are trying to build similar opportunities for health improvement in India. Thanks so much for this amazing opportunity. Thank you.
Thank you, Dr. Anand. I would like to invite Dr. Hari Menon. Yeah, Q&A? Yeah, okay. We'll have a Q&A section.
I know it's already 9 o'clock, so we'll keep it very brisk, very quick questions, very quick answers. I'd like to take 100 questions in the next 5 minutes.
I said heart failure, natural heart failure is reversible. What about atherosclerosis? Is atherosclerosis reversible?
Atherosclerosis is reversible for the last 30 years. DNORNISH showed that. Denise Chiartas you met, she is in the intense cardiac rehab program. So atherosclerosis of 80%, 90% lesion in the LAD can go away. But the trouble is, who is this going to go away? How long is it going to take? We don't know. So we place the stent. So we don't compete with evidence-based medicine, which requires PCI for symptomatic coronary artery disease. But the symptoms and their interventions are only for specific lesions. But the disease process is throughout the body and throughout the coronaries. And for 30 years, we know it can be reversed with lifestyle. But still, the penetration of that type of DNORNISH reversal is very low because people don't want to make that level of change. Our program is, I would say, much easier and it is much more real world than DNORNISH program. And our program works on atherosclerosis as well as even more advanced issues like heart failure. You would look at atherosclerosis as a process that develops between 40 to 70 years. Heart failure as something that develops between 60 to 90 years of age. So even the entire spectrum, including atherosclerosis, we are able to reverse with advanced cardiac energetics. Yoga, exercise and diet amazing question. Once we want a meal, we don't have only rasam or only poriyal. We want to have everything, right? Like that, I feel all of these should be included in a real holistic approach. But I use the word mindfulness. I don't teach yoga. I teach the mind aspect of yoga. Self-inquiry is what we teach. So that, I think, plays about 70 to 80% role in the success that you're seeing. Because if I did only lifestyle, my success will not be this dramatic. We can get only 5 to 10% weight loss. With only exercise, it's nearly futile. There is really no weight loss through exercise. So the mindfulness, empowering, I think, is the biggest role.
Throw some light on the program, like what you do, just outline, if possible.
Advanced cardiac energetics is using natural ketosis. So my heart, I'm now 51 years of age. In 2018, I had had 3 meals every day, and I was a busy cardiologist. So my heart was fueled by glucose and free fatty acids, just like everybody else's heart. But in 2018, although this program started in 2015, for the first 3 years we did not use natural ketosis. So from 2018 we used natural ketosis, and in the last 3-4 years only we started tracking it at home. So we empower people to make ketones in their liver. So that is why we call the actual program Advanced Cardiac Energetics. And this comes because of 2 reasons. One is mental relaxation or mind yoga. The second thing is reducing calories in a way that is safe and sustainable. So when we show people that they can do this comfortably in their circumstance, some people like this food, some people like that food, some people like lot of food, for whatever they like, how do we empower them towards this natural ketosis? So that is what takes lot of our energy, to look at people's individualized lifestyle and diet and guide. So that is what is this program. And for this, how do we deliver it? So this program is delivered initially as the heart age estimator. So whatever test is taken to measure the heart's biological age, and then tell people that your heart is 23 years older than it should be. So as soon as we tell them, we want to also simultaneously tell them how young we can get it at the earliest possible. So we want to show them how much of it is reversible. For some patients, there's not much reversal potential. They have burnt out diabetes or they have advanced heart failure. So we want to be realistic about their expectations. So that is the first thing, giving the right knowledge. Second thing is we have videos, and we have a book that I wrote called Seeking Hunger. It's about the self-inquiry, mindfulness aspect. So this type of material that patients take home and do it at home. Third thing is weekly phone calls. And those phone calls address their virtual care, which is based on their metabolic health, their blood pressure, their weight, their lifestyle, their glucose, their ketone levels at home. All of this we are able to track and guide them on a once a week or twice a week basis. So all of this put together, using the technology and the medical team that delivers my approach to the patients, is what is Advanced Cardiac Energetics. That aims at transforming health through these lifestyle interventions within 12 months. 12 months. If this magic is not happening by 12 months, I recommend they find a different cardiologist. I am still happy to take care of them, I'm just kidding. But I mean, this program will work in the first 3 months. Many times they are already referred to me from several other specialists, so they are motivated. When I was in Missouri, I was just doing it as part of wellness on my weekends and evenings. But now this is part of my official day job. So people, when they come to me, they understand that this is what the expectations are from their own doctors and their own families, that they participate and learn it right. They've already had 2 or 3 weight loss surgeries over the last 20 years. They've tried Manjaro, Ozempic, and achieved whatever benefit they can, and still they are losing their life when they come to me.
What we are suffering from is our own making, actually, right? And what I forgot, one was stress. So we have to somehow manage stress also. And I think such programs are going to be very successful in this era when, as you can see from the figures also, that what you have is obesity is also increasing. Diabetes is a sort of a offshoot of obesity, hypertension also. And they are all interrelated. So one of the most important things is that we need to change how we are actually looking at our health also. And that mindset has to change from being, well, sort of totally sedentary, what we are becoming, to something more active and doing change in the lifestyle, so that, like what you are suggesting, and this I think is one of the best solutions, and this can prevent further damage to whatever health we have actually damaged.
This is the most important thing. If we cannot change the mindset, if we cannot change at the core of what we like, then this is unlikely to succeed. But those who have succeeded in our program have not regained any weight. So all the success stories, if you go talk to them, they will not have any fear of regaining the weight. That fear is there even after weight loss surgery, 1, 2, 3. It is there after Mounjaro Ozempic, but it is not there after our program, because our program starts with empowering them towards the right direction. Thanks for bringing up. And stress reduction is built into our program. Unless the stress goes down, people cannot make the ketones that is needed for advanced cardiac energetics. Otherwise, you have to go into starvation. 4 or 5 days of eating nothing will only make some ketones. That is not sustainable. That's not real world. We make ketones within 8 hours, 12 hours, because of the way we empower people. And we have to guide them, individualize it and guide them. That's how we are seeing by 10 months dramatic weight loss of 40, 50, 60, 65% through natural ketosis. And this natural ketosis also is not unique to our program. Mounjaro, Ozempic and gastric bypass surgery also utilize the same natural ketosis. Only thing, nobody has been tracking it for the last 50 years. Whereas I took it upon myself for the last 4 years to track it and guide patients based on it. That's the only difference. And I encourage everybody to track it on your patients. Excellent. Thanks for bringing up that valuable role of stress. Once they find a medicine for stress, they'll add it. Mental, cardiovascular, kidney, metabolic syndrome. Until they find a medicine for it, they don't have a need to add it to anything. Once they have $1 million injection, then it will come. Some more questions?
Good evening, sir.
Good evening.
I have 2 questions, sir. One is regarding the role of...
No, you are between our dinner. I'm just kidding. I'm not the reason for the delay, but really appreciate the questions. Thanks so much.
What would you consider the role of Trizipated in the near future in way of controlling the visceral adiposity, sir? Because it works by reducing the adiponectin, whatever that plays a role via the adiponectin. So does it have a scope in reducing the visceral adiposity as well in the near future? And how do you see the scope of the drug in the near future, sir? Next question is, how would you correlate mindfulness while eating to the obesity prevalence, sir? Because most of the times these days we tend to eat by not with mindfulness, and we tend to watch something and binge eating.
Excellent, excellent questions. As far as which fat to address, I have not focused on that till now. Only in the last few months my attention is moving towards fatty liver, because that is the most atherogenic fat. Epicardial fat and liver fat are the highest atherogenesis. Next is visceral fat. Finally, the least metabolic is the subcutaneous fat. So we just focus on the right intervention through holistic engagement, and all the fat goes down. And if it's not visceral fat, then we have to address it more. But between weight loss surgery versus injection versus lifestyle, our ACE program, I don't think there is any specific value to any specific fat. But visceral fat needs to be addressed. And that is what we are, if there is visceral fat and the body weight is, see, I don't look like I have extra weight in my body. But if my visceral fat by MRI comes up as a high number, then I need to continue to work in the right direction. Do you see what I'm saying? But I wouldn't be good candidate for injections, but I'll try more lifestyles. Did I answer that aspect of the question? And then this mindfulness and diet and obesity, without the mindfulness, even if you take Mounjaro injection, weight does not go down. And injection, people are not able to take it all lifelong. 1 year maximum they take it. After that, the weight will come back. So while they are on the injection, we want to teach them the right way of empowering them, so that they might have a chance of really succeeding and potentially coming off the medicines. Excellent, thanks. Couple more questions and then we can stop. I am here all evening. I have nothing else happening. People who, anybody? Yes, sir.
Yes, sir. So in a patient's perspective, I would like to know how to convince a patient to get engaged to this program, because the patient's question is how many hours a day or how many consultation do I take in a week, or how much do I spend for this. Either it would be a money or financial part, or it would be the time. Should I spend day doing exercises, or should I spend doing calculating my calories, or what should I do? When do I consult the doctor? How frequently?
In the US, for the last 2 years, this program is covered by insurance because it is embedded into the cardiology care. So patients don't pay out of pocket for the AS program. But the actual program, I had made it free since the pandemic on YouTube. So that is what they are getting it through the mid-levels, medical assistants and my team. But if we want to bring it to India and actually show results, it's going to cost. And we want to place it very similar to Manjaro. Manjaro costs about 2.5 lakhs a year. So we want to say maybe at that price point, people who are really motivated will sign up, and within 1 year, they'll not only get to lose weight, we are targeting biological heart age reversal and potentially coming off these injections also. So several benefits we can give. And this is the price point, about 2.5 lakhs per year for the first year. And very likely they won't need it throughout life. Once they learn this right after this first year, they won't probably need it. That's what I'm expecting. And that is the cost. As far as time, how much time should they spend on this? The answer is 0 time is what people need to actually do the program. To learn it, it's about 20 to 40 minutes, 8 times over a 2-month period, and 1 or 2 phone calls over the week, just to make sure they are in the right track. But the actual program, we don't expect people to spend 2 hours in the gym at all. No time in the gym, no specific diet, no specific, food supplements to inject. But then how to make the natural ketones using the right mindset. And the reason I don't emphasize exercise is because I deal with very sick people who already have heart failure. Exercise is unsafe in heart failure. That's why we don't emphasize exercise. But then once they start getting really healthy, like the successful patients, then they start exercising, they get to more and more on their own. And then I support that also. I guide them on which exercises are safe.
So just to give an extension of what Dr. Anand said on the commercials, on the price point, as he rightly said, the package in the US is in the range of around 2.5 lakhs. So what we are actually planning is to give as an introductory offer or something, we would like to price it at 1.25, in the range of 1.25 as a package. But this basically will involve 2 stages. One is a diagnostic package, which we will do it in-house at VMHS. So we have 3 different packages on the diagnostic side. One basic, another one is advanced, and the third one is a complete. So once those diagnostic packages are done, which basically is a set of blood tests and imaging, then the next part is getting into the ACE program, which Dr. Anand had been explaining this longer time. So this diagnostic package will vary anywhere between starting from 2,000 to 20,000. And the whole package, the ACE program, to start with, at least for the next 3 months, we are planning to run it at 1.25 to 1.3 lakhs, and with differential payment options as well. So that is a plan that we have. Depending on the patients that are being referred, we could give even more detailed breakup of these packages.
Any other questions?
Sir, good evening. You were explaining about heart failure with preserved ejection fraction. So what about the patients with heart failure with reduced ejection fraction? I mean, this is
I'm interested in diastolic or preserved ejection fraction because we cannot do balloon, stent, surgery, even guideline therapies, none of them work. Cardiac rehab is not even reimbursed in the US. So they are not even candidates for cardiac rehab despite them having all these metabolic problems. So for them, I developed this program but it works equally well for heart failure with the reduced ejection fraction. So if people are motivated, we work with them, but the reversal, EF of 20%, for that one gentleman, I showed you 40-year-old, his ejection fraction normalized. For him, the ejection fraction was down because of his metabolic problems. But I cannot just generalize and say this program will fix heart failure. That's why I say it works on diastolic heart failure reversal. For systolic heart failure, if it is due to prior myocardial infarction or myocarditis or some other prior underlying condition, the reversal potential will be lesser. But if there is extra weight, if there is extra stress, if there is metabolic load, this program can definitely make them much healthier, much younger, and reduce medicines just like it reduces medicines for diastolic heart failure also.
Okay, thank you.
In your view, were able to bring it under the insurance cover. Probably there could have been some specific effort that you would have taken to really make it aligned with the cardiac related cover. So if something like that has to happen in India, what is your thoughts about it?
So I believe at least in our culture about 50% of the time there is some insurance coverage, 50% of the time is out of pocket. That is what I'm hearing in Chennai at least. So if it is out of pocket, then it's still going to be out of pocket. But if it's insurance coverage, then we have to show value. Insurance companies are ultimately, in the US at least, paying for everything that happens, including medicines, including hospitalizations, surgeries, interventions. Everything is coming out of the insurance company's budget. So factoring some risk, they are insuring people. So if we reduce cost from 40 medicines down to 2 medicines, the insurance company is saving those 38 medicine cost, and readmission rate, when we bring it down by 95%, the insurance company is happy because that's money that they've saved. In India also we have to show value like that. So then only the insurance companies will buy in and say, this program we will support, we will incentivize, and we will allow you to build. So all of this is going to happen in the next 2-3 years. In the US as it happens, I believe insurance companies here will also similarly start supporting us.
If you have created this value proposition of this program, the ACE program, so you would have pursued with the payers there to see how to...
See, I still stay as a cardiologist. I've not done any business interactions with the insurance companies, but the institution, Vandalia Health, where I work, they believe this level of transformation is needed for their community, and they are, first they needed to show some outcomes. That's what I showed, 90 patients showing dramatic results. So that is their negotiating point. Till then, they supported my work to show that it can, because before that it was only wellness on weekends. Those pictures will not sell for insurance companies. But now we have outcomes in the first, actually 200 to 400 patients we have, but the 90 patients we have consolidated the data and we have sent it out for publication. So that will inspire insurance companies to start funding medical teams and whatever resources I need to succeed, because when I succeed, they save money. So we can show there is 10 times value for them if they support us. So that's the process for the next 1 year. So this is not wellness. This is intervention, just like balloon angioplasty or bypass surgery. This is an intervention that people have to accept, buy in, and come in with their family and realize they have to participate. And the only opportunity for us is because of remote patient monitoring that insurance companies are supporting in the US. And the biggest opening for us is Mounjaro and Ozempic, because they showed the way that weight loss is the path towards health. So then we are riding the wave now. Although we started before them, doing the right thing takes longer.
Those who are already taking some medication,
so you are asking specifically about autoimmune conditions, right? Yes. Like thyroid disease and
rheumatoid arthritis, SLE, like that. They have to take some lifelong medications.
So this program is through natural ketones. This has been much better than I anticipated 15 years ago. The results are getting even better after I came to West Virginia. So this scope we have not explored. So if we start trying this program, I would suggest we try it on people with extra weight in their body, because for our people to succeed, if there is no extra weight, it's a little harder to do the program. But today, if I develop SLE or rheumatoid, I will definitely lean towards this, because the benefits are really multiple levels. So bring down C-reactive protein dramatically, 80% reduction. That's what we see. And obesity is only one of the reasons. So by reducing inflammation, I genuinely believe autoimmune diseases will come down. But I've not had a chance to directly focus on that. When I say 38 medicines are going away, many of those medicines are for depression, arthritis, hypertension, diabetes. So autoimmune diseases specifically I've not looked at, but I genuinely believe it will reduce the need for medicines and symptoms will get better. Thanks for that important question. Thanks so much. Thank you.
Thank you, Dr. Anand. I would like to call Mr. Suresh Samuel, Chief Strategy Officer, Vinayaka Research Foundation, to felicitate Dr. Anand. I would like to call Mr. Suresh Samuel to felicitate Dr. Nallam, Chairman, Clinic Nallam. I would like to request Mr. Suresh Samuel to felicitate Dr. G.R. Ravi, Director, Chennai Diabetics Care. I would like to request Dr. Selvam, Consultant, General Medicine, Vinayaka, to felicitate Dr. Shiva Subramaniam, Cardiologist, WIMS, Salem. I would like to request Dr. Selvam to facilitate Dr. Moharan, Professor of Surgery, Manakula Vinayakar Medical College. I would request Dr. Selvam to felicitate Dr. Rajshekhar, Professor of Surgery, Venkateshwara Medical College. I'd like to request Dr. Selvam to felicitate Dr. Sudhakar, President of IMA Puducherry. I would like to call Dr. Vidyavati, HOD, General Medicine, to felicitate Dr. Swati, DMS, MGM, CRI. Thank you all. I would like to invite Dr. Hari Menon, Medical Director, Vinayaka Mission Super Specialty Hospital, to deliver the vote of thanks.
Good evening, all doctors and all dignitaries. It's my honor and privilege to deliver the vote of thanks on behalf of the management and the organizing committee. First of all, I would like to thank Dr. Anand for taking your precious time coming here, not just for the speech, even today morning, a lot of enlightening sessions were there, given to our PGs and fellow colleagues. And I would like to thank each and everyone in this forum. I wouldn't take much time in the vote of thanks because already we are very much ahead of time. I'm sure all of you have been starting feeling hungry. So thank you everyone once again. Let's proceed to the dining area, please. Thank you. Yes, one more thing. Tomorrow we are going to have the inauguration of this particular PACE program in the hospital. So morning 10 o'clock. So once again, thank you, and let's all proceed for the dinner. Thank you very much.